Children Advisory Group. Thank you all for spending your time with us today. We're excited to delve more into some medical home data for our state and have some conversation about that. So I will note that this will be another sort of data heavy-ish presentation day or meeting day. But we hope we'll learn some things, and we've structured it so that way we can have some more small group conversation and sort of larger group debrief. So, and then our April meeting, we're going to shift a bit to have that be a little bit more discussion focused and kind of talking about systems that we all sort of interact with. But we'll share more about that later today. Next slide, Lindsay, please. Um, here's our virtual meeting guidelines. Many of us know these, but just please stay on mute when you're not speaking, just to reduce background noise for others. We'd love to see you. If you're able to share your video, feel free to use the chat or raise your hand at any time for questions. Try to stay present and engaged. We have a lot of things that we would love to get your thoughts on, and then just practice patience and understanding because we're all at different sort of places, and we each, have different perspective to bring to this work and these conversations. And then if you get disconnected, rejoin. We'll be here. I was presenting a little bit ago, and my internet went out. So, but luckily, folks stayed with me. All right, next slide. We just wanted to kind of just remind folks, because I know not everyone has been able to attend, so I'm just going to do a quick recap. So sort of the project purpose is we want to for this project, so why we sort of have gathered this advisor group is to really understand the current pediatric medical home landscape and system gaps within our state. There's no real one coordinating body doing this work, so we're going to endeavor together and try and figure it out. And then we really would like to be able to identify Title V, so that Title V Maternal Child Health Block Grant. It's the role that it can have in advancing medical homes for children across the state. We know that will be more geared toward public health strategies, but we have a lot of partners in this work, and many of you are seated here with us today. So we want to also be thinking at the same time about ways we can engage partners to work in spaces to advance medical homes where we, as public health or state government, might not be able to as effectively. And then we'd like to at least select sort of at the end of our sort of process here, select at least one pediatric medical home system gap to focus Title V's support on in the coming years. Next slide, please. And this slide just gives you sort of a few examples. I'm not going to run through every single one of just public health strategies that we can be thinking about or might be able to implement sort of after we go through this process. These are just sort of generic, but obviously after we kind of work through our process, we think we can have some specific lanes um, for us, and then we can be a bit more detailed in what those strategies will look like. Next slide. This is our timeline. So, yep, as I stated earlier, this is sort of our third meeting. It's a bit of a fast and furious process. So we do have another sort of numbers heavy presentation day, but we've tried to break it up and give folks some more time to get to know one another a little bit better, and then also have some good, just some rich discussion around the data that we're presenting today. Next slide. I'm not going to go through every single one of these, but these were our community agreements that we as a group sort of agreed upon kind of our very first meeting in January, which feels like an eternity ago now. So we just ask that you all be open, respectful, or be respectful to one another and just actively participate. And then next slide, please. And then, if for some reason you feel like conversation may not be going in a particularly helpful direction, or you're not being heard, just here are some kind of ways in which you can refocus that conversation or frame kind of how we're speaking to each other. Next slide, please. Okay, and I think I turn it over to you, Lindsay, right?
Yep. Yep. Thank you. Thank you, Jessica. So just going through a quick recap of our February session, information and the things that we discussed. When we started our session last time, we opened it up with sort of a question about like what contributes to a child's health, like what are contributing factors that influence the child's health. And so we created a word cloud from some of your responses, and the words that stood out the most, or the ones that were most repeated, will appear larger in this word cloud. And so I feel like, we all just did a really good job thinking through how health is multifaceted. And as you can see here, we have, of course, health being the largest word that appeared, but, the importance of, access to care, emotional health, physical health, um, feeling really safe and secure, having social and supportive environment. So, and then we took that conversation and led it into a conversation about, okay, disparities. So what might lead one group of people to experience like worse outcomes than others or better outcomes than others. And then after we took a look at the data, we sort of tried to identify what are some disparities that we're seeing coming up over the data that were presented. And we have a summary slide here that sort of highlights the key themes that you all really uplifted in our February session. And you can see that differences in health and wellness that were highlighted last time by this group included differences by insurance type, where we noticed that Medicaid, individuals on Medicaid might have differences in health, worse health outcomes than those with private insurance. Age was also a disparity that was noted by some of the data, older children versus younger children. So maybe not older children not participating in as many well visits as younger children. We highlighted differences based on sexual orientation with some worse outcomes based on LGBTQ youth versus straight youth. Race and ethnicity was another factor that you all uplifted. Non-Hispanic Black youth versus non-Hispanic white youth. And then finally, children's special health care needs status with different indicators highlighting that some worse health outcomes based on children with special health care needs versus those who do not have children's special health care needs. And then part of the reflection process, we asked, what else do you want to know? What might be important to find out? And on the right side of this graph, you have important questions that you all raised together. So relationships, like how does transportation impact health? What's the difference between providers accepting Medicaid versus private insurance? Where are they located across the different counties? You all wanted to know information about how does family size impact children's health, like the number of kiddos in a family, how might that influence whether they're participating in well visits or receiving their immunizations. You wanted to know information about family type, so single fathers, individuals in foster care, those maybe with incarcerated parents, how might that influence health? You asked questions, really good questions about the relationship between parents' education, age and disability status on children's health outcomes, as well as healthcare provider shortage areas for different specialties like dentists, pediatricians, and federally qualified health centers. And so we are working to answer some of these questions. Some of them, there are a couple of additional slides at the end of the slide deck, and I put the slide deck in the chat. You also received it through email. Some of them we're continuing to work on, and then I just encourage you all to continue thinking this way. As we look at the data presented today, please continue to think of what disparities, what differences are you noticing, what other questions are coming to mind, and we'll continue to reflect on this and document them so that we can use it moving forward when we're thinking about what do we actually want to address as a group and what strategies might we want to employ. So this is really helpful throughout to continue us on in the process. So for our goal today, we're going to dive into, like Jessica said, some additional data. And so we're going to look at those three, we're going to talk about the data sources, and there are three main pieces of data we'll be talking about today. The first is measures of insurance access and healthcare services. The second, and this is where we'll be diving into sort of small group discussions just to make sure everyone's voice is really heard and captured, is medical home components. Really dives into the medical home specific data. And then finally, the rating of public health care systems, or CAHPS data. So we have a lot to cover today. We're really excited to share the data with you and to hear your perspectives and, from either your personal experience or your professional experience. So this is sort of the main goal and the main sort of the plan for today. So I'm going to pause and see if anyone has any questions about our agenda. All right, so what we're going to do is we're going to practice our small groups by doing some introductions. So what we're going to do is I'm going to have, in just a minute, I'll have Gloria open the breakout groups. We'll be whisked away into breakout groups, and every group will have a facilitator. And so we'll just ask that you introduce yourselves, your name and pronouns, if you're comfortable, your role as a parent rep, an organizational rep, like what hat are you wearing today to this session? And then just starting to get us to think about what medical home means as we're going to be diving specifically into that data. So how would you describe medical home for children to a friend? So like if you met someone and they were like, I don't know what that means, how would you describe it to them? And so this doesn't need to be a long, like super lengthy description, but just really quick as we go around and introduce ourselves. And then if you're like, Lindsay, I don't remember what that is. What is a medical home? We have a little cheat sheet for you. And so I'm going to put in the chat right now a PDF of the slides that are relevant to our introduction. But here's our little cheat sheet. Your facilitators will have access to this. And these are sort of the main components of a medical home. So it's in the chat as well. But I'm going to go back and I'm going to see, does anyone have any questions about what we're doing before we go into our breakout rooms? Okay, Gloria, you ready? Okay, can you please launch the breakout rooms for us? Thank you. You should see an invitation to join. All right. A few more folks rejoining us. I'll share my screen again. How did it go? Was it nice to meet everyone? I just wanted to just take a quick minute just to see if I could get one or two people to just do a quick like recap of like a takeaway from their discussion, a point that sort of stood out to you about something someone said that maybe really stood out.
I'll start. Our group asked me to share my my definition, which I stole from somewhere else that I found. But so this bottom line of a patient-centered medical home is where your primary care team cares about you while they're caring for you. So kind of a succinct definition.
Awesome, thank you. Would one other person like to share anything that really stood out to them from their discussion?
Hi, this is Lisa, and I apologize, I'm not on camera. I'm awaiting a new computer to be delivered to my home because my camera's not working. But I shared with the group, I have a niece that has pretty significant chronic conditions, and she's had to navigate essentially her whole life. And one place that she does go to is her medical home. She calls it her medical mall, and she loves it because she has to travel to go there. But when she goes there, she actually goes to her provider, goes to her specialist. They do the tests all while she's there. And she said, yeah, it's like I have to go there for a couple of days to get everything done. But then once it's done, they all sit down as a team and work together and go over my case together. And she said it really eliminates having to know, like, I went to my specialist, but oh, now the test results didn't get to my provider. So, oh, now they don't have this. And so it really improves the communication, and she feels like they're working together as a team for her best being. And so she loves going to the mall. She said that's her favorite time is when she goes to her medical home, which is out of state.
Thank you, Lisa. Thank you for sharing that. I really like that. I think that's a really great story. So, and a really good example of what it should look like, I think. So thank you. Okay, I'm sure that you all had wonderful conversations. I know that my group had really great things to share. Just in the interest of time, I'm going to move us forward, but we'll definitely have more chances to talk with one another. Okay, I'm going to turn it over. Who's my next person? Dr. Gilmer?
Oh, my next? Okay.
Yep. Are you next?
Oh,
Hold on, let
no,
me see.
no, that's me.
Nope, it's Gloria. I'm sorry,
Sorry about
Gloria.
that.
You're next.
No worries. No worries. Yeah, so today we're going to be, like Lindsay has mentioned, we're going to be spending the bulk of our time reviewing data on the health system and medical home for children in Michigan. We're going to look at key measures related to insurance access and healthcare services, how people are accessing those, as well as then do a deep dive into the National Survey of Children's Health Medical Home Composite Measure. And then if there's time, we'll review healthcare system ratings from Medicaid and the Children's Special Healthcare Services. All right, so the data sources that we're going to be pulling from today include the National Survey of Children's Health, that's the big one, the Michigan Consumer Assessment of Healthcare Providers and Systems, otherwise known as CAHPS. And we're also going to be looking at a modified CAHPS survey that Children's Special Healthcare Services did. Some of this data is also accessed through the Title V federally available data set, particularly that National Survey of Children's Health data. And then we're also going to be discussing the Community Voice Assessment from the Title V 5-year needs assessment. And that included listening sessions with community members and parents, focus groups with parents and youth, parent and provider surveys, as well as some secondary data that we looked at. Next slide, please. All right, and so as we go through the data, we want you to keep these questions in mind. This is kind of what we're going to be discussing after each chunk of data that we look at. What disparities or gaps do you see? How does this data fit with your experience? And what do you want to learn more about, or what data is missing? And so for our first chunk of data, we're going to look at measures related to insurance access and healthcare services. So I'm going to pass it over to Lindsay Towns.
Okay, thank you. So yeah, as Gloria was saying, we're going to be looking at some data related to insurance access and healthcare services. The vast majority of these data, I think all of these data actually come from the National Survey of Children's Health, which I'm just going to give a quick overview about that, since we're going to be seeing these data quite a bit. As the title gives away, the National Survey for Children's Health is a national survey that is conducted every year. It is a random sampling of the US population of children. And it's one of the only good sources for children's health data that we have that are collected in a standardized measure year after year. At the state level, we kind of do run into some issues where, because of how the sampling frames are built, we often don't have huge numbers of responses from people in smaller population groups. So we're often lacking good data on our Native and tribal populations, on our Asian Pacific Islander populations. And sometimes when we start getting into the more granular data on children with special health care needs, we often very quickly run out of data on our non-Hispanic Black children, on Hispanic children, and so on, even though those are larger groups within the state of Michigan. So that's just a little bit of background on the survey, and then we're going to dip right into the data now. Go ahead, next slide. All right, so this first one is adequacy of health insurance. So I want to be clear that these data are, the denominator for these data are children who have health insurance. And in Michigan, the children who do not have health insurance are consistently a fairly small proportion of children. It's usually something on the order of 2 to 3% due to programs like My Child and so on. So one of the things that we do note, and adequacy of insurance here, so continuous is for the past year that the child was insured for the entire year, and adequacy has to do with Does the health insurance meet the children's needs? Does it adequately cover costs? How much out of pocket costs do you have, and are they onerous or burdensome to the family? So one of the things that I do want to highlight on this slide is how children with special health care needs are significantly less likely to have had adequate insurance in particular compared to their non-CSHCN peers. And in one sense, this isn't surprising because these are children who do tend to have both more complex and greater health needs. And so those costs we could assume would, pile up, but we do have programs, CSHCS, for example, that are meant to address that. And yet we're still finding that these folks are struggling to have adequate insurance. Next slide. Again, we're looking at the continuously and adequately insured population. This has to do with family income levels. So this is the percentage of the federal poverty line for families. And as you can see, once you start, there's actually, these differences are not particularly significant, which might be a little bit surprising, but it is important to remember that there are programs in place for families who are below the poverty limit or within certain percentages of the poverty limit to ensure that their children are insured, and that we actually start running into some trouble with our more well-to-do families. Those families that are making 400% of the federal poverty limit or more had a real drop in 2021-22 compared to 2020 to 2021. So this is something to be aware of. Like, family income is not necessarily as correlated as you might think with adequate and continuous insurance for children because of programs that are in place for children who are living in poverty versus those who are not. Next slide, please. Again, we're looking at the continuous and adequately insured variable. And one thing to note here is that non-Hispanic Black children have consistently, not just for these years presented here, but consistently been more likely to have adequate insurance than non-Hispanic white children over the period presented here. And this goes back to at least 2016 when the National Survey for Children's Health changed some of their methods. So previous years aren't necessarily comparable, but this is a long time trend of Black children being more likely to have continuous adequate insurance than white children. I couldn't begin to get into all the reasons why that might be, but just note that this is something that has been documented for quite a while by these data. Next slide, please. Okay, so children who were unable to obtain needed healthcare. So adequate is defined in the survey. Thank you, Amy. Adequate is defined in the survey. It's got several different components to it, and this is actually a composite variable put together around questions of current health insurance coverage, whether the coverage is sufficient to meet children's needs, whether the insurance allows the child to see needed health providers, how much out-of-pocket costs there were for healthcare, and whether these costs are reasonable or burdensome to parents. Those questions are asked individually to parent respondents and put together as a composite variable. So we're not just asking parents, do you have adequate health insurance? Okay, I see you nodding, so we're cool. So the inability to obtain needed health care, once again, children with special health care needs were significantly more likely to report being unable to obtain needed health care compared to their non-CSHCN peers. This is another set of data, and this will come up over and over again with this data set, that getting race ethnic data breakout can be challenging just because of how these data are collected and the small number of people who are actually surveyed within the state. But this is something where we do see a fairly strong disparity with between children with special health care needs and those who do not have special health care needs. So close to 10% of children with special health care needs unable to obtain needed care. Next slide. Okay, so this is specifically the denominator here is children with special health care needs who receive care in a well-functioning system. And again, this is another composite variable where parents are asked individual questions and then they're put together into a single measure. So the parents would be asked, does the family feel like a partner in their child's care? Does the child have a medical home? Medical home is itself a composite variable, and so on and so forth. So you can see what these pieces of the well-functioning system are. And children with special health care needs, a very small percentage, 14% of children with special health care needs received care in a well-functioning system. And this is even lower for the non-Hispanic Black children with special health care needs. So we're talking about a massively underserved population in terms of having adequate insurance, receiving medical and dental preventive care, feeling like a partner in their care, no unmet needs or barriers to service, and transition to adult healthcare. So these are all major issues with for children with special healthcare needs in terms of accessing the healthcare that they need. Next slide, please. Okay, preventive dental visits. So that is essentially a well visit in the past year for children ages 1 through 17. Michigan and the US have been pretty comparable on this measure for quite some time. And this is one area where we find children with special healthcare needs are more likely to have care than children without special healthcare needs. So children with special healthcare needs have consistently been in the mid 80s, and children without have been in the mid 70s in terms of receiving a preventive dental visit in the previous year. And this is not getting into receiving needed dental care at that point. We're not talking about, did you get fillings? Did you get this and that? This is cleaning exam, essentially. Next slide, please. All right. So this data here is children ages 0 through 17 who have a diagnosed mental or behavioral health condition who receive treatment or counseling. So when we're saying they're receiving needed treatment or counseling, mental health treatment, this is among children who already have a diagnosis. So we're not talking about children who are going undiagnosed, which I would argue is a form of not receiving needed health care, of course. But I just want to be clear what the denominator is here. What we found is that Michigan has traditionally outperformed the US on these kinds of metrics, but we've been dropping down since our high point in 2018-19 and becoming more like what we see nationally. So we have a decrease in the percentage of Michigan children who have diagnosed mental or behavioral health conditions and are receiving needed treatment. Again, this is a measure with limited stratifying data. That is, it's hard to break out to look at subgroups on this one. Next slide, please.
Thank you, Lindsay. So first off, I just wondered, are there any immediate questions that are coming to mind?
And just to clarify, this is the parents reporting whether the child got
Yes.
dental first. Okay.
Yeah, we are not the only survey I know of that asks children directly about their well visits is the Youth Risk Behavior Survey, which asks adolescents. So in this age group, very difficult to get these data.
And the children with special healthcare needs population, does that include behavioral health needs as well as medical needs?
That's a great question. I think it's whomever qualify. I don't know what all the qualifying. Oh, you know what, Lonnie, I see you.
Yeah, we should confirm this, but I believe the answer is yes. That the definition in this survey for children with special healthcare needs includes physical or medical as well as behavioral health special healthcare needs, and so it's an important point for us to share in that it's a much larger population than those who are eligible for CSHCS in Michigan, and it actually Sarah's comment speaks to a question that I was going to ask, and that is, is the data available through this survey? Does it allow us to distinguish between those different types of either behavioral or medical? And I don't know the answer to that, but it's a question that comes to mind as I was reviewing these slides. So maybe that'd be something for follow-up. Thank you.
No, there certainly is a list of included conditions. They have an initial household screener for inclusion, and I do think things like autism disorder and so on certainly do meet their qualifications, but it appears to be more related to the care that a child needs to receive rather than a specific single diagnosis or type of need. So is there ongoing care? Do they have to see multiple providers? Do they need specialized therapy? These are the things that go into building this particular survey's definition of a child with special healthcare needs rather than the diagnostic list that we might have for the supplemental medical care system in Michigan.
Thank you. Okay, so I'm going to pause there. And first off, just open it up to the first question. So, and we can, anyone can put it in the chat. We can say, unmute. Love to hear your voice. What are some major disparities or gaps that you saw? I know there were quite a few that really stood out. So What is something that really stood out to you? And I can put the slide deck back in the chat for us in case you want to have it open yourself. What are some gaps that you all noticed?
There were, I mean, definitely gaps among children with special health care needs and non-CSHCN kids. Obviously the one, I mean, not obvious, but like the one that like really stood out to me was ability to obtain needed care. That seemed to be the most significant gap.
Carrie?
14% is a very low.
Thank you. What else really stood out to folks? We can go back to slides too if needed.
I guess what stood out to me is that it's not really necessarily related to having health insurance, because that didn't seem to be the problem. They were more likely to have insurance. It's just they're not getting the adequate care that they need. So there's all those other factors that are perhaps more important than simply having insurance, however that's defined.
Thank you. I think that's a really good point. I saw a lot of head nods and thumbs up from the group. What stood out for others?
It was interesting to me to see the decrease in the mental health treatment after 2018, 2019. 2018 and 2019 was the first decrease, but then it decreased further. I wonder if maybe COVID has something to do with that. Typically, if it's a child, maybe virtual visits for that type of treatment wouldn't necessarily be I don't want to say helpful, but functional for an adolescent or child to get those type of services virtually. So I wonder if that has something to do with it. But it was a continued decrease after as well, after the pandemic. But so that stood out to me.
Thanks, Tia. Seeing a lot of head nods for that as well.
Following up on what Tia said, I think of it as a percentage, but is it because the numbers increased so dramatically, right? That the percentage went down, even if the numbers went up. So I'm saying, like, if the numbers of children in need went up so dramatically following the pandemic that it just couldn't keep pace, so the percentage actually went down. Be interesting to see the hard numbers too.
Yeah, that's a really good point. I feel like there was at least for me in my own, like for question number 2, with the personal experience, that the increased awareness of mental health needs like across the board because of the pandemic, I think was really uplifted. So that might be a really good point, Amy. What else? What else is sort of speaking to you or fitting with your own experience?
I'll just say that, going back to Dr. Meyerson's point, where there is appears to be fairly adequate insurance coverage, but the well-functioning component of that just seems to be really low. And that's obviously how it draws upon a person's experience in the healthcare system. And to me, and I'll just go to my personal experiences, the healthcare system is very complex. So it goes to that case coordination piece, I think. I don't know that that's specifically measured in the data. We didn't really talk about that, the composite pieces, the components of it. But I'd be curious to know whether, that was an area that people felt was missing in their experience to get such a low, well-functioning score.
Thank you.
I will kind of go off on that. That has been my experience. I mean, I teach at a community college. I have the same insurance that our teachers have across the state. I have very good insurance, and we've had a terrible experience throughout all of our daughters different medical needs. So it definitely is not a coverage issue or even the type of insurance. It's just a failure of the system, in my opinion.
Thanks for sharing, Vanessa. I'm sure there's a lot of people that have a similar experience, unfortunately.
For sure.
Anything that, I know we had some questions. Oh, wait, hold on. I see something in the chat. Gloria shared could be showing capacity issue for mental behavioral health treatment. Okay. I think that's for another conversation, but yeah, definitely. Is there any other questions that are coming to mind for folks? Like anything else that we'd want to learn more about, or other questions? You've had some good ones so far.
A question about the data about Black children are likely to have continuous adequate insurance. So that brings me to think about, is it because they have they qualify for that Medicaid or Medicare insurance because they're below the poverty line? And then also the response to doing the surveys. Is it, to me, it seems like it's a cultural thing between, it said natives, Asian, non-Hispanic Black children who not a huge response to those surveys. So that goes back to your question, if that fits with my experience. And I feel like I do see that. I guess I feel like it's a trust issue, or like a cultural issue of having trust with the medical system for those communities not to answer certain surveys for some, their reasonings.
So I do want to
Thank you,
say
Tia.
that is certainly possible that there is a difference in response rates between racial groups in Michigan and nationally. But what's a larger issue in this survey is that the strategy they take in sampling, they don't necessarily oversample smaller population groups, which is an approach that other surveys do take. So for example, the Pregnancy Risk Assessment and Monitoring Survey intentionally oversamples Black moms, Native moms, moms who live in Metro Detroit, because we're trying to make sure we capture adequate numbers of those populations in Michigan, because they're populations of interest with regards to pregnancy risk. This survey doesn't necessarily do that. And if you're not intentionally oversampling those populations, you are going to run into probably undersampling them in reality, where you end up with disproportionately low numbers of responses, even from small groups. Because if you're just randomly sampling a population and you have groups that make up less than 1% of that population, and you're not even sampling 1% of the population, just by chance alone, you're going to miss a lot of those smaller members of those smaller groups, whatever those groups are, however they're being defined in a survey. So while there certainly could be an aspect of different response rates to the survey, I think there's also an issue with how the sampling of the populations are conducted in the first place, and just not being able to adequately capture smaller population groups, especially at the state level. They'll have big enough numbers to be able to report these data nationally, but at the state level, they often fall down because it is done at the national level.
Thanks, Lindsay, for highlighting those limitations. Yeah, that's really important to note. And I like your point, Tia, about sort of that cultural like hesitancy and mistrust, maybe like not willing to fill out the survey or not even wanting to contribute. I see Lonnie put in the chat, the preventative dental visit data was surprising to me. CSHCN are more likely to have had the preventative dental visit than none, and wondering why that is, given the broad concerns about access to dental care for this group. Thank you. Okay. I'm gonna last call for any like thoughts or notes before shifting to our next section. All right, perfect. Okay, so, all right, Dr. Gilmer, now you're up.
Okay, so I'm just going to go over again, since this is kind of the core concept of this group, is what is a patient-centered medical home? And obviously, it's not a place or a location of your medical care, but rather it's really the experience you have when you go there. So it should be easy to get into, like things like accepting your insurance and getting an appointment when you need it. Once you're there, the staff should be listening carefully to your concerns, treating you with respect, and responding to your needs in a caring and compassionate way. So the care you receive should be cradle to young adulthood. Should be everything your child needs to stay healthy, and it works with you to make sure your child gets the care they need across that complex healthcare system. So the goal is to obtain maximal health outcomes. Next slide. So the core elements of this model include all these aspects that you see here. It's a physician-led healthcare team that you have a personal and ongoing relationship with, and all aspects of your healthcare are considered, and the team coordinates what you need across this complex healthcare system. Quality and safety are embedded into the office so that best practices are consistently used, and there should be hours of operations and methods of communication that really allow easy access to your healthcare team. And finally, there should be a payment model that enhances and allows for all this to happen. So these are all the components we've been talking about all along, and just keep these in mind as we go through the next set of data.
Lindsay, you're back up.
Okay then. Hello again, everyone. So yeah, we're going to be talking about the actual medical home performance measures from the National Survey for Children's Health, which do differ a little bit from what Dr. Gilmore was just talking about. So we are looking at another, what we would call a composite variable. So this is a variable that's put together from the responses to other survey items. In this case, a medical home is defined as that the child receives care from a personal doctor or nurse, it's their usual source of sick care, that the practice provides family-centered care. And then the last two are a little bit more conditional. So it's for children who need referrals. Is there any difficulty in receiving those needed referrals? And for those children who need care coordination, is there any difficulty in receiving care coordination? Are there any issues with care coordination? These are the 5 components that go into the National Survey for Children's Health definition of what comprises a medical home. Next slide, please. So before we get into the data, this is a discussion piece that we've had a couple times with other groups when we're talking about these kinds of variables. And these variables, when you're dealing with a variable that's made up of other variables, you'll note that the components that go into that composite variable often have higher values than the overall composite variable does. And people want to know, why is that? If 80% are saying they're good on this and 80% are saying they're good on that, why are we suddenly seeing that it's only 60% who are good on both? And the reason for this is, if your survey is well designed, each of those components will be an independent measure of a specific aspect of medical home. And in this case, it is a fairly well designed survey. So in statistics, this means that responses to one item do not affect the responses to other items. So in other words, people who say yes to this is my usual source of sick care may or may not respond yes to any of the other items, or they may respond yes to some and no to others. So when you're dealing with truly independent measures, this can lead to kind of counterintuitive variable values. And I wrote this out, and then as soon as I sent it out to the group, I was like, why did I not refer to this in terms of coin flips, which are much easier to understand? When you flip a coin, you have a 50% chance of head or tails. But if you are flipping a coin 5 times in a row and they all need to land heads, you know that it's not going to be a 50% chance of that happening, right? It's going to be much lower than 50%. And this is what we're looking at with a lot of these data. So if we have 5 items where 90% of every item is a yes response, our composite value can be as low as 60%. It would be 0.9 times 0.9 times 0.9 times 0.9, which brings us to 59.5%. These data are not perfectly independent. This is real world, not a mathematical model. People are not coin flips. So it'll be maybe a little bit lower or higher than the perfect example. But another thing to bear in mind is that a single no response to any of these components will lead to an overall no on medical home for that individual. So even if they're meeting 4 of the 5 components, if they don't meet that 5th one, that's a no for them. So just to get that out of the way and hopefully clear up any confusion in advance. Next slide, please. All right, so overall, the percentage of children with and without special healthcare needs, ages 0 to 17, who receive care in a medical home, there's a fair bit of variability here. For Michigan overall, it's right around 50%, and it's been hovering there for a while. pretty comparable to the US as a whole. White children are a little bit more likely, and then Black and Hispanic children are considerably less likely to report receiving their care in a medical home setting. And again, these are not parents who have been asked, does your child receive care in a medical home? They're asking us, responding to a series of other questions, and then the survey is putting them together into this. Next slide, please. For comparing children with and without special health care needs, children in our most recent data year here, children with special health care needs were significantly less likely to report having a medical home compared to non-CSHCN in Michigan. And a big chunk of that is going to be related to the fact that children with special health care needs are much more likely to report needing care coordination and needing referrals. And so those are two more variables where they have a chance to be a no for the coin to flip tails essentially on this. So that's one of the major contributors to this disparity, and especially as we're moving through, the pandemic years and so on. Next item, or next slide. So now we're looking more at the component measures of what goes into medical home. And the first one we're looking at here is children who have a personal doctor or nurse. This is a personal doctor or nurse who knows the child well and is familiar with their medical history. And right off the bat, you can see that there are some racial disparities here, with white children being 80% of white children reporting having a personal doctor or nurse versus 62% of Black children. Right off the bat, that's a major difference that's going to contribute to disparities in this overall medical home variable. Michigan as a whole, again, pretty comparable with the US, not really big differences there. We're not falling behind the country, but where we are falling down is in helping and making sure that our Black children have a relationship with a personal doctor or nurse who knows their history. Next slide. This is children who have a usual source of sick care. So that is, you're going to the same doctor for sick care and not just going to whichever urgent care or ER or other source of non-medical home type care. And again, we're seeing a significant disparity. Probably the most significant piece of this data is the difference between non-Hispanic white and non-Hispanic Black children, a 20-point difference. So here we have children who, as we were thinking about in our healthcare access and insurance slides, we know that Black children are more likely to be insured, but they're significantly less likely to have a usual source of sick care when they fall ill than white children are. Next item, next slide. The next component is family-centered care. So family-centered care, this used to be called culturally relevant care in the survey, and they've changed the phrasing to family-centered care. So this is, do the child's doctors spend enough time with the child, listen carefully? Are they sensitive to the family's values and customs, give needed information? And does the family feel like a partner? So I'm going to be clear that this is also a composite variable. Those are the items that go into it. So we're not just asking parents, do you receive family-centered care? Because how many people would know off the top of their head precisely what that means, right? So this is something that's defined by the survey. Once again, we're seeing not as strong of a difference between non-Hispanic white and non-Hispanic Black children as we saw in the other items, but still a fairly substantial disparity. Pardon me, I'm going to mute so I can. My child was sick last week and she gave it to me, and now here I am. So, but we are seeing a pretty significant disparity here between non-Hispanic Black, non-Hispanic white, and Hispanic children with respect to culturally competent family-centered care. Next slide. Okay, so referrals, once again, this is a conditional variable. So first, families would have to respond that they needed referrals for their children. And this has to do with any difficulties in receiving needed referrals. So this is not all respondents, whereas the first three would have gone to all three respondents. Michigan families have typically been less likely to report difficulty in getting needed referrals, but we are becoming more comparable to the US as we get closer to the present time. And why that is, I am not a student of the healthcare system, so I couldn't precisely tell you, but this is an ongoing, it's an increasing issue for Michigan families who need referrals. Next slide. Okay, so care coordination is another one of those components. This one is, again, conditional. It's for children who need care coordination. So the questions involve if they needed help arranging care, if it was needed, did they get it, if they got the level of coordination desired, satisfaction with communication between providers, communication with schools if desired, and level of satisfaction with that. Again, we see a large disparity here, but unusually that disparity is with Hispanic families being much more likely to report adequate care coordination than pretty much anyone else in the last couple survey years. But once again, non-Hispanic Black children are being left behind in these measures, although not significantly worse than white children, but for whatever reason, the care being provided to at least the Hispanic families that respond to the National Survey for Children's Health in recent years have had better luck with care coordination than other groups. Next slide. When we look specifically at the differences between children with and without special healthcare needs, we see that children with special healthcare needs are more likely to report receiving needed referrals, and they're more likely to report care coordination. I'm sorry, I've got that precisely backwards. Children without special healthcare needs are more likely to report receiving their needed referrals and with receiving needed care coordination. And I think that's actually really a shame, because one thing about children with special healthcare needs is they have special healthcare needs. Like their needs for these services are much higher typically, not just needing a referral to one specialist or one additional providers, but many. And so the need for that care coordination is much higher typically than children without special healthcare needs. And this is one place where we do see significant disparities that I think are clinically significant. Next slide.
All right, so I'm going to go over some of the qualitative information that we got during the Title V 5-year needs assessment. And so just a reminder, these were done from MPHI and the state team doing focus groups, surveys, listening sessions, etc., with parents, providers, and community members. And we found the following themes that apply to all children, and then the next slide will go into themes specific to children with special healthcare needs. But for children overall, in the focus groups with parents, there was a general lack of knowledge about what a medical home is or how it works. And parents also shared about challenges to accessing care for their children in general, as well as accessing medical homes. And some of challenges that were brought up were financial burden or insurance issues. In a survey to providers, some of the major themes were the need to increase provider staffing and retention, the need for more familiarity about medical home model among providers, the need for more robust care coordination, and also education for families about the value of a medical home and receiving comprehensive services. And then in some community listening sessions, we heard that there's a need for assisting both older youth in navigating the healthcare system for themselves and for parents as caregivers. And also we heard about the need for a safe and affirming care for LGBTQ+ youth. Next slide, please. And then specific to children with special healthcare needs, in focus groups with parents and caregivers, we heard about limited access to providers, specifically around that specialty, subspecialty care and finding someone locally, as well as the need for mental health to be kind of incorporated into a medical home approach, the need for family-centered care, care coordination, kind of those components of the medical home, as well as the need for accessibility and support services. Providers shared the lack of specialty or subspecialty providers at the local level. Parents and caregivers bringing up limited transportation options and financial barriers as kind of reasons why they are struggling to get the care that they need for their children. I also mentioned the need for better care coordination between providers and understanding of the medical home model. as well as more support and training for caring for children with special health care needs who are more medically complex than other children. And we also looked at some secondary data reports and saw that university or health systems-based practices report more ease when it comes to providing care coordination than private practices. So that's a really interesting kind of systems piece to look at. Barriers to specialty care are kind of come up a lot around transportation, appointment times, kind of lack of continuous care with the same care team of having to take your kid to multiple providers who aren't necessarily talking to each other. But another thing that we did see is this continued investment in the state programs like the Children's Special Health Care Services and other children with special health care needs serving practices, really aiming to identify needs and connect families to resources. So that's an area of current investment, historical investment, and something that we could use more support though, based on what families and providers are saying. So yeah, we can go on to the next slide.
All right, so we are going to go back into our breakout rooms, and we're going to have between like 10 to 15 minutes to discuss these 3 questions in our small groups. And then for our facilitators, we'll sort of keep tabs with each other with the chat and see how we're doing with time. I'm putting in the breakout room slides in the chat so you all can have access to just the medical home slides. But yes, so that's what we're going to do. Hi, everyone. Welcome back. I hope we had some good discussions. I know we never have enough time together. And so I'm definitely going to make a note for that for our next meeting, likely to plan some extra time for this. So, but I know that our group had some really good points and thoughts and wonderings about the medical home data and a lot of personal experiences shared. So I thought that that was, at least really illuminating and good for me to hear, and that documented that. But I just was wondering, just to get a couple of folks to share maybe some key points from your discussion. So what was something that you all shared in your group that really stood out to you, or questions that you had that you might want the full group to think about or consider? And I guess I'm gonna maybe a call on a group, group number 1, which is Kemi's group. Could someone from that group just sort of share one key takeaway from your discussion?
Yeah, I can go ahead and on behalf of my group. So we talked in terms of disparities and gaps. One of the things that came up was around the usual source of sick care, that wanting to understand like what was influencing the barriers or influence around that, like what the differences and communication needs, like, what kind of influence some of those barriers or influences behind the usual source of sick care, and the fact that Hispanic community also had reported higher coordinated care. So wanting to understand what some of those facilitators around the Hispanic community and why they had reported better coordinated care compared to others. And then when it came to the experiences and how the data aligned with their experiences, folks had brought up the fact that, I had a quote in there that someone said, I'm my daughter's care coordinator, and kind of having to take on that responsibility of advocating on their behalf and their child's behalf to make sure that their child is properly coordinated and getting everything they need, especially if the system has let them down in the past.
Thanks, Kemi. That definitely resonates with what was shared in my group as well. Sarah, your hand's up.
Yeah, I just wanted to share when we talked about connection with our experiences. One thing that came up was this theme around potential things that might be driving some of the issues that we're seeing. And one might be the belief that accepting care coordination and help with that is perceived as a weakness or a lack of independence. And that might be, it might be stigmatized particularly in some cultures or geographic regions to accept help in that way. So there was a curiosity about how to change those perceptions, kind of maybe building on some of the work that the mental health community has done to destigmatize getting help for those kind of conditions. Like, how can we change the narrative around getting care coordination as well?
Thank you, Sarah. Yeah. Anyone else? We have time for one more comment or sort of key takeaway from our discussion.
In group 3, we talked about the siloed nature of mental health and physical health in Michigan in particular, and how even one of our persons was saying that there was a mental health provider embedded right in the office, and many times couldn't get patients to be seen by them because of insurance coverage and the way that we reimburse in Michigan. So there was that, and there was also, we talked about the fact that care coordination takes a lot of time, takes staffing, and that the reimbursement models don't compensate for that component of it. So you really are trying to do care coordination without the proper staffing. So just wanted to add those 2 things.
Thank you very much. Thank you all. Thank you for the great discussion. We've captured your notes. I'm going to exit this just to scroll us down. We are not going to ignore this data right here. We're definitely going to talk about it next time. We just wanted to make sure we had enough time to do discussions, and we don't want to just rush through something and not make it meaningful. So we're going to hold on to that. I am putting in the link to our evaluation in the chat. We definitely want to hear from you about how you felt like this meeting went, opportunities for improvement. Our next meeting is going to be on April 23rd, and we're going to start diving more and having more discussion-based meetings about like the experience with the system. So very curious to hear from like providers' perspectives, really wanting to hear from parents' perspectives. And I feel like we just got to dip our toe in a little bit today. I know that like in our group, we really had that conversation about, well, this language doesn't quite fit with us, like what the survey is showing, or, I'm a parent and I'm really, challenged by these things, and I'm having to be an advocate for my own child. So, I think just really having that opportunity for us to discuss more of a systems experience and how that's impacting, various folks and what their experiences have been. So that will be our next meeting. Again, please complete the evaluation. That's super helpful for us. And we just really appreciate your time. And if you do have any questions, please reach out to myself, Jessica, anyone on our sort of core team and the state team, and we'll be happy to help. And the recording will be available. So for anyone that may not be able to attend or missed out on part of it, we'll make sure to send out all those resources and things for you. So I'm going to stop sharing. Does anyone have any questions before we all say goodbye? Last minute thoughts, questions? Okay, well, we truly appreciate your time. Thank you very, very much. And we hope you have a wonderful rest of your day. Bye, everyone.
Yes, thank you all. Have a good day.